Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. For those I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department and CAR 609. On behalf of Dr. Andy Pollack, our medical director in the medical director's office, on behalf of our EMS office, Director Shenning, Captain Stewart, Captain Natz, thank you for what you guys do every day. Thanks for being here. Thanks for your dedication to lifelong learning. A big shout out today for Ashley Brooks. Ashley is one of our volunteers at Pikesville, and she is helping us run this Zoom platform. Ashley also is the one who is going to be sending out a text in the chat function. Keep an eye on the chat. She'll send out a link that you can click during the presentation to get your CEUs. So if you want your CEUs, make sure you keep an eye out on the chat. We'll also announce it. And make sure you click on that link and give us your information. If you have any challenges with getting access to the link or entering your information, MIMS requires that we resolve this today before the end of this presentation, before this training ends. So feel free to send a text to or a chat privately to Ashley or I if you're having any challenges whatsoever getting your names into the CEUs when Ashley sends out the link. So tonight we have representatives from the Association of Independent Midwives in Maryland. We have Bayla Berkowitz, Hannah Morgan, and Deanna Kopf. Our speakers today are all advanced practice providers and professional midwives. Collectively, they have attended over 1,150 births. You guys, thank you so much for joining us. Thanks for sharing your knowledge and your expertise. We super appreciate you.
Thank you. I want to really express our appreciation to all of you for all the things that you do. We have been trying for a number of years to reach out to the, to your community to kind of teach you all and discuss together what we do. That when you come, when we call you for a home birth transfer, that you kind of have an idea of what we need and what the situation is that we're dealing with at that point. So we are midwives. I'm a CNM, which is a certified nurse midwife. That means I have a bachelor's in nursing and then I have a master's in nursing, specializing in midwifery. So it's like a nurse practitioner type of degree. It's an advanced practice nurse. I've been a midwife for 13 years, doing home births now for 5 years. Deanna, Hannah, and a lot of our other midwives are CPMs, which is a professional midwife. It's a specialty of midwifery that is out of hospital specific. They have, it's more of like an apprenticeship program. They have a didactic learning and it's a minimum of 2 years and a certain number of experiences, certain number of births. So it could be 2 years up to 10, 15 years, depending on how long it takes to achieve that experience. But our specialty is specifically out of hospital birth. I did work in a hospital for a number of years. A lot of midwives also work in birth centers. The other thing we wanted to talk about is the legality of home birth. Home birth has always been legal for the person who is giving birth. There has been a point in time where it was difficult to find a provider who could legally attend a home birth. Nurse midwives for a while needed to have a physician backup. So a physician that would sign off that they were willing to back up the midwife, for all of their care that they were providing. And that was difficult to find a doctor that was willing to back up a midwife to do out of hospital birth. That requirement went away a few years ago. So now nurse midwives are completely autonomous. So there are more nurse midwives available now to do home births. CPMs recently became legal a few years ago through the legislative process. So before that, they were not legal. So again, that was another reason why people think that home birth was not legal for a certain point. But now we are all legal and we are all attending home births. Home birth has become a lot more common and a lot more requested recently, especially due to COVID, but also just due to poor experiences in hospitals and with physician practices. So we are getting a huge influx of clients choosing to birth outside of the hospital setting. In general, our philosophy for a home birth midwife is very hands-off. We really don't intervene unless there's a reason to. And that's, because we believe that birth is a natural process that should be able to proceed uninterrupted. The majority of home births are happy, successful, normal births. We say about, I think, 11% transfer, and only about 3% of those are emergent transfers. So our number one reason for transfer to a hospital is maternal exhaustion. So the laboring person has been in labor for 3 days and just needs an epidural and some Pitocin to get their labor going, but usually not an emergent situation. And then Hannah, you want to talk a little bit about other reasons why we might transfer?
Yeah, thank you, Bayla, and thanks everyone for being here tonight and for your time. I was going to spend a little bit of time talking about some of the equipment that we bring to births, and also some of the reasons why we might be calling EMS to come help us. We are now licensed, so it gives us a very clear legal scope of practice in which clients that we can accept to attend their births at home. So all of our clients, before we even arrive at their home birth, are low-risk clients. So they don't have chronic hypertension, they don't have signs of preeclampsia, they don't have risk factors that would make it more likely that they would hemorrhage or really become an emergent situation. We carry with us oxygen, we carry with us the medications that would be able to handle a hemorrhage, the same medications that they would actually have in a hospital to handle hemorrhage. We carry with us resuscitation equipment to resuscitate infants. So if they are born and they need help ventilating their lungs, we can handle that at home. Most cases of that. I'm trying to think, is there something I'm forgetting? No, those are the things that we carry. So we're able to handle like shoulder dystocias, we're trained in how to handle hemorrhage. Things where like it would risk someone out of a home birth would be like carrying twins, having a breech baby that was not able to turn prenatally, having any other risk factors that would make it more likely that there would be an emergency. We wouldn't even try to have those births at home.
And actually CNMs and CPMs have different regulations. So CNMs actually can do multiple like twin births, breech births. Also vaginal births after cesarean is something a CNM can do legally that a CPM is not currently able to do at home.
Thank you, Bayla.
But I just wanted to say, sometimes we do have surprise breaches, which we can handle at home.
Right. And that's sometimes why we would call EMS. So when things go kind of awry off of our plan and we are surprised by either the presentation of a baby or twins, or sometimes there's a hemorrhage that we're not able to control. Sometimes when the waters break, there's a cord that the baby sits on that can compress their oxygenation. And that's something that would indicate a cesarean birth. So not to be doing that at home. Sometimes the babies need more help in getting their breathing going than we're able to provide with our basic neonatal resuscitation equipment at home. So that's another reason why we would call EMS. And we just wanted to be clear that when you guys show up, we are, their clinical providers were making the call that we need to go in to get help to a more appropriate care setting. And we have established relationships with our clients, so we are sources of clinical information that we can work together to get our clients and babies to the right, more appropriate settings. Do you guys have any questions about that? Or Deanna, do you want to?
Yeah, so I was just going to talk a little bit about what we need from EMS during a transfer. So what the most important thing I think is a smooth transfer of care. Usually, as Hannah said, the two most common emergencies that we are calling EMS for at a birth is resuscitation of the baby, or a baby who's not coming around, not breathing, or a hemorrhage. So in those circumstances, for instance, with a baby who is having trouble, we leave the baby attached. We don't cut the cord right away because we want the baby to get all of that good oxygen from the blood from the cord. So we probably would wait until the very last minute to take care of that. So once EMS arrives and is ready to take the baby, then we would cut the cord and separate the baby. Also, it was mentioned that we use a resuscicradle for resuscitating, and probably in the transfer of care, we would also hand the baby over with the resuscicradle because they need to keep their airway open, and the resuscitation needs to continue. So, so that, you know, is one thing that I have seen a couple of times, is that sometimes there's a lag in time there from when we, you know, we are bagging the baby and then we hand the baby over. They might take a little break while they get the baby to the ambulance, and the least amount of time that can happen is best. Also, again, hemorrhage is another reason why we might transfer. Most of the time we can get those under control with the medications that we have. But sometimes, you know, a mom might be showing some symptoms, you know, feeling lightheaded or dizzy. That seems like maybe she lost too much blood. So in those cases, we do, you know, call EMS so that they can go to the hospital and be monitored to make sure, you know, they haven't lost too much blood, or sometimes they may need, you know, a transfusion, or sometimes they're just monitored for a few hours and given some fluids and then sent home. We also do carry fluids with us, so we can do IVs, and we may, you know, start one before EMS gets there. So, you know, we might have an IV started already. Oh, and I just wanted to say as well that we, you know, since we train in these things, we also are recertifying in CPR and neonatal resuscitation every 2 years. So we have to stay current on those certifications, and our assistants and students who work with us are also current in those. And then clear communication is really important during that time. You know, usually once the EMS arrives, we try to have, you know, vitals, the latest vitals that we've taken, and we'll give all of that information as well. And we also give that information to the hospital, and we'll fax over the client's records to them, you know, so that they have those records when they get there.
Yes, I wanted to show everyone what the resuscicradle is. One of the biggest concerns we have when transferring a baby is that a lot of the ambulance, you know, personnel will say that the baby needs to be in a car seat. And a lot of times we're transferring because the baby's not getting enough oxygen and needs that, you know, oxygen support. And if you hunt over a baby in the car seat, you're compressing their airway even further. So there's a midwife that came out. It's actually an older version of it. The new ones actually have, like, you can see this so well, have like tabs along the edges that you can attach to a backboard that you can actually like tie down. But this is made so that the baby's head goes here, and so the head is kind of tilted back a little bit, and that the baby's in a really good position for CPR. So what we would like is to be able to keep the baby in this resuscicradle. We also carry large Ziploc bags or saran wrap, which we would use to put over the baby to keep the baby warm. So we're worried about the baby's breathing, and we're also worried about the baby's temperature. If the baby gets too cold, then that's very concerning and it's very dangerous, and newborn babies cannot maintain their temperature. So in order to be able to continue chest compressions and be able to see chest rise, we would wrap the baby in plastic to preserve that, the warmth. So we carry plastic bags or saran wrap. So these are actually, the new ones are actually made to be able to be used in an ambulance setting so that the baby can be kept safely in this. I realize this might be against your protocols, and I don't know what those are, but we have had a lot of people say that the baby needs to be in a car seat, which is kind of concerning from where we're coming from. So you'll see this with a lot of home birth midwives. Any questions about this? And somebody posted the website for the resuscicradle as well.
So there was a question in the chat that asked if the baby is okay, but mom needs to go to the hospital. Does the baby have to be transported with the mom?
No, baby does not in most cases, especially now with COVID. A lot of hospitals are not even allowing the babies in. And we can send the baby, you know, with dad in the car or whatever. In most cases, like I said, most transfers are not emergent. If mom is able to get to her car, we usually try to transfer by car if possible. So we would only call you if she, you know, was so faint and couldn't walk or couldn't get down the stairs. If it was really an emergent situation that we could not get her to the hospital by car. Any other questions?
I'm sorry, I wanted to add, how do you want us to handle questions? Straight into the chat, or do you want them spoken?
I think either is great.
Okay.
Sure.
Okay. So I see a number of different attachment points on the Recessive Cradle. Can you describe or give us a link that we can see how the Recessive Cradle is marries into or interacts with either the Furno stretchers or the Stryker stretchers?
I'm not familiar with types of stretchers, but you can look at their website. It was made specifically, even comes with straps so that it could be strapped down onto a stretcher.
Terrific. All right, thanks.
So I can look through some of the chat. So other midwives present, Mari Rothman is a CNM, one of our midwives. There's a Diane. I don't know if that's our Diane or another Diane, but I think that's all the midwives that I see on here. And yes, 3% of transfers are of the 11%. So there's 11% transfer rate, of which 3% are emergent. We do try not to separate moms and babies, but usually if somebody has to go by ambulance, a lot of times they will not take the baby with as well.
There's a question about the cradle certification and whether it can be used for transport. I certainly don't know the answer.
Yeah, I don't know about that.
That's a good question.
I mean, the person who developed it, I don't know, but I'm assuming she did some kind of research into regulations, but she's also out of state, so I don't know if there's any difference.
Well, hold on one second, right? I mean, the Recessive Cradle is a tool not for transport, it's a tool for resuscitation, right? I mean, this device has been well studied in the medical population and is strongly advocated for. I don't know where they are with AHA recommendations, but there's plenty of evidence about the positioning of the baby and the use of this type of a tool. But this device then has to strap to somebody. So you would never use this device, particularly I'm speaking to those who asked the question, you would never use this device to transport a patient. This would just be, similar to the equivalent of a backboard for an adult. It still needs to be secured into some device. You would never put this in a seat, for example, and transport that patient in that device. This is just during resuscitation.
It's just, it also maintains a good airway. So if the baby's having issues.
Yeah.
And what type of suction do we use? We have a DOLA suction. Like, we have very basic suctions. In general, most babies do not need to be suctioned. There are some more advanced, kind of manual suctions devices that are available, but we don't use suction very often at all.
For everyone, Ashley sent out the link in the chat as well. It looks like it's a bit.ly link /midwife20. If you guys want to sign in real fast.
We had also discussed maybe offering some experiences that we've had where we've called EMS to maybe give some more situational anecdotes to
Great, love it.
bring us out.
Yes.
I can think of
Do you want to start, Hannah?
which birth. I can think of one where I was working with Deanna. We arrived at a home birth and there was a foot hanging out, which would be a breech presentation, which is not what we were anticipating. And we were able to safely birth the baby at home, and the baby did need resuscitation, and we were able to stabilize everyone and stay at home for that situation. But we called EMS as soon as we saw the foot coming out, in anticipation that we may need to resuscitate this baby, and we may need to do that, move to a hospital quickly if we weren't able to handle the resuscitation at home. And I think that experience went very well. I think the scariest part is just like people come in and they're not sure what situation they're walking into or who's necessarily in charge. because we wear like plain clothes to birth. Yay, the Recessive Cradle.
Mm.
Yeah, that's how it looks with the baby strapped.
Yeah, and it accommodates the baby's big head and allows that head to fall back.
The most important thing from our perspective is that the baby's airway is open.
Exactly. Yeah, more of a sniff.
Yeah, through the whole way on their way to get to a NICU.
Any other questions, you guys?
I have a question. So I'm wondering if there has been a time when you've needed to actually transport with your patient to the hospital.
We prefer to if possible. We would like to go. I mean, before COVID, we tried to, all the time, just have somebody there to support them and also to maintain whatever the issue was. Like I said, we carry medications for hemorrhage. So if she's hemorrhaging, we can come with and bring the Pitocin with. If the baby needs to be transferred, we can continue doing neonatal resuscitation, which we're, well trained in. So if possible, we do like to go with the client in the ambulance.
You guys good at IVs?
We are.
Do you intubate?
We do not intubate. We are trained in neonatal intubation, but we don't do it frequently enough to be confident in our skills for that.
Us either.
We're so grateful
That
to
would make me, I've
live.
intubated hundreds of adults. That would make me crazy anxious.
We're
Other
grateful to have
situation.
here where we have EMS that can quickly get us to experts that are more experienced and confident.
Yeah, so there's a question, is a midwife able to direct on-scene care from an EMS perspective, and can they determine hospital choice? So as part of our care, my own practice, we do all of our prenatal visits in the office, but we do one home visit to kind of scope out their house. And during that visit, we ascertain what their closest hospital is. So we create a whole transfer plan as part of our routine care, that if there's an emergency, where are we going to go? And also, what's your preferred hospital? So if it's not emergency, where would you like to go? So, that is something that we have written down on their chart at the home. So when we do need an ambulance, sometimes we might say, like, if they're kind of equidistant from two hospitals, we might say, can you go to this hospital? And you can always say no, of course, but it's something that we have discussed with our clients ahead of time. We discuss all emergency, possibilities and all transfer possibilities with them, so that they are aware that it is a possibility they might transfer. And yeah, we would be happy to direct on-scene care. I had a transfer recently where the 911 operator told them that the baby had died, and that was not the case. So they came expecting a dead baby. So yeah, I took them aside and I kind of told them what was going on, who was running, who the midwives were, who the client was, what the issue was, and why we needed the transfer. That was actually a hemorrhage. She had been bleeding for a while. We tried many medications and she just continued to bleed. So she was not able to get up, go to the car, anything like that. So we called for a transfer in that situation.
Can I add something to that, Bayla?
Sure.
Hi, I'm Mari Rothman. I'm a midwife with Mamas Inc. in Tacoma Park, Maryland. We serve the Montgomery County and parts of Prince George's and Howard and Arundel a little bit. I've been a midwife for 25 years. I've caught over 1,500 babies. And I can still count the number of emergency transfers I've done on my two hands over that huge amount of time. But I would say my answer to that question of are we able to direct the scene from an EMS perspective, I would say yes, at any home birth transfer scene, we are going to be the most qualified person to direct the scene because we are professional OB providers. And so, at least in my practice, we try to stay with the if it's a mother transferring, that we try to stay with her until we can hand her off to the next OB provider, understanding that you guys need to be incredible generalists. You need to be able to figure out how to handle anything that comes along, but because of that, you can't really specialize in any one thing. And that's what we do. So we do try to, we do have the intention of directing the scene as long as we're there. And of course, we understand that you're coming into a scene in progress, and that the first thing that you need to know is what's happening. So we're really good about, as soon as you arrive, saying, I'm Mari Rothman, I'm the midwife in charge here, and this is what's happening. These are her vital signs. These are, giving you all the data so that you feel comfortable that you know what's happening. And then just making a plan with you for what happens next. And I have had situations where, not too long ago actually, I was at a birth that was between Holy Cross Hospital and Washington Adventist Hospital, but a little bit closer to Washington Adventist. And the EMTs were so wonderful in that transfer, because I said, we were transferring because of the baby. And I said, this baby needs to go to Holy Cross. They don't have a high enough level NICU at Washington Adventist. And the EMT called ahead to Holy Cross and said, we're coming in with a baby, sirens blaring. And the hospital said, our ER is full, don't come here. And he said, okay, see you in 5 minutes. And we just went, because he understood that their ER was closed because of adults, but the pediatric, NICU was not closed. And so they were really great about doing exactly what that baby needed, which was the most important thing at that point. So we do often discuss with EMS, like, where the best place would be to go for whatever the situation happens to be at the moment. And we understand that sometimes people are on diversion, and that's the way that it is.
And we also, in general, call ahead. So once we determine which hospital the client's going to, we'll call them and give them a report so they're ready for us and they know what's coming. And we have, we send their chart. We do all electronic charting. We can fax their chart ahead so that they'll be ready to take over whatever the emergency is.
And they often, when we get to the hospital, they often say, do you have a copy of her chart? And we usually say it should be sitting in your fax machine. It gets there before we do, because it can be teleported in a way that we can't. Maybe in the next century we can do that too. But
I love this question. How can EMS improve the care?
Can I just chime in real fast? I would
Sure.
just respond to that. I would think that most providers would be relieved to have somebody there. This is a very high risk, low frequency event for our providers. Anyone who says that they're comfortable with all of this, unless they do it during their day job, there's no way. So I'm reluctant to ask the question if you've had issues with EMS, but I think it dovetails nicely into the question that Kus is asking in the Q&A, the chat.
Yeah, and I think one of our biggest concerns with transferring babies is maintaining an airway and warmth. And because we are trained in neonatal resuscitation, we would like to go and continue resuscitating the baby in the ambulance until we get to the hospital. So that is something that we really want to do. We've had people come in, grab the baby and run the baby to the ambulance. And we're like, wait a minute, the baby's freezing and not breathing. And, please let us help you get that baby settled. That would be really helpful. Yes.
I can give you another example. One time, and it was with the best of intentions, and we totally understand it. And I think a lot of times it comes from the EMS people not understanding what our scope of practice is. And that's the reason for having this gathering, is so that we can understand what each other's function is in that transfer scene. But one time I went to a birth, and the mom was in pretty good active labor. And she seemed like she was in the middle of her labor, not at the end. And she said she felt like there was something in her vagina. So I checked her cervix and there were feet in her vagina, but she was only maybe 4 or 5 centimeters dilated. But she was in good, strong labor, but we don't intentionally do breech births in my practice. So we called 911, because we're not going to put a person with feet in her vagina in a car. So we called 911 and they came very kindly and, heard the story and started to take her out to the ambulance. And the EMS person, I don't know what his title was, but he looked like he was about 18 years old, so probably not an advanced person. and he said, you can ride up front. And I said, no, I stay with my patient. And he said, well, what are you going to do? You're going to do an emergency C-section in the rig? And I said, no, but I might do a breech delivery unless you want to. And he said, okay, no, go ahead, get in. But so I think it was just a misunderstanding. He didn't really understand what my function was there. And that's, it's not a really frequent occurrence that we have transfers. So a lot of people, a lot of EMTs have not ever been at a home birth transfer because they're pretty rare. And they might not necessarily know what it is that we do and what we're capable of in terms of the care of our clients. So I think this kind of information session is really great for helping everybody understand what you're supposed to do and what we're supposed to do and what you're good at and what we're good at.
So there are a lot of questions in the chat publicly to everyone as well as to me privately, and I don't know the answer to this. I don't know if you do either. Do you have any idea whether paramedics and EMTs in the field can take medical direction from you?
Legally?
Mm-hmm.
What's the question?
If medics in the field can take medical direction from you. So for example, we have a very structured protocol. Midwives are not mentioned, to the best of my knowledge, in these protocols. It says that we can take direction from on-site physicians, for example, but there's nothing around midwives.
My understanding of the law, and I've looked into this in the past, is that in most jurisdictions in the US, the law states that whoever is the highest credential on scene at an emergency is in charge. So we're going to be that person.
I'd like to step in here on that a little bit. And I think one of the things we've been able to do over the past years, it's much better than when I started out, is being able to recognize who can do what. If it's putting in an IO or something, we may be better equipped at that if you have to do that to the baby. For intubation skills, it may be the individual provider. The general rule is once somebody calls 911, whoever makes that call, it's saying that you can no longer handle the situation. And therefore you've enacted the EMS system. Again, in most cases, if you do something that we as EMS providers can't do, you're licensed to do it and you accompany the patient, you're probably okay, and we're probably okay. If you can meet those, it's within your scope of practice, not mine, and you are doing it and you are accompanying the patient that you have a relationship with. It doesn't really matter who's got the gold badge. It's good patient care.
Exactly.
And as Sean has said, that you have to, whether it's the advanced nurse practitioner or the paramedic or an EMT, you have to be able to quickly soul search and say, who's going to do the best for this patient right now? Because that's what the outcome's going to be. And so I think it's much better than when I started right now.
You know, I think in concept, that's all. I think that this is all great. I do think that it's worth probably kind of addressing this issue with MIMS, because I definitely think that, you know, some of the tension that may be experienced in the field, you know, may be, regarding a lack of clarity in terms of who's responsible. You know, because the EMS providers definitely operate under a very strict protocol and with severe repercussions when they violate that protocol. You know, there is certainly, you know, a just culture. You know, I don't think anyone's willfully violating it, but I think based upon the number of questions that we're getting in the chat and me privately alone about this topic, it's probably worth clarifying.
And just anecdotally, what I've seen and heard many stories are of when midwives make the call that we can no longer handle this at home, we need help. Time sometimes is wasted when EMS arrives because we're all trying to figure out, like, what's your role? What's your role? Where are we going?
Right.
And so if we can, as a community, become more comfortable with each other and figure out what our roles are before we're in an emergent situation, that would be amazing. And
Yeah.
we would feel more confident calling for help, knowing that we would be able to get to where we need to go more quickly and efficiently.
And if I were to start an email, could I just tag one of you guys on it? Bayla, you've been my contact. Tag you on. Just
Definitely.
To see, yeah, just to see where we can take this. You know, they may be interested in addressing it. MIMS.
Yeah, and I wanted to address this question, how can EMS improve the care we provide in the emergent birth experience? And that's kind of what Hannah just mentioned. I mean, historically, we're nervous to call 911 because we don't know how we're going to get treated. We don't know how our clients are going to be treated. You know, a lot of times can be a hostile, you know, situation where, you know, they kind of grab the patient and say, what's wrong with you? Why are you, you know, pretending to be a medical provider, you know, taking care of somebody at home? And we only transfer what we call like our train wrecks, you know, so the hospital, the 911, everyone sees the train wrecks that, you know, you don't see the beautiful births that happen. And so many of them are beautiful, they're safe. And we want the respect. We want our clients to be respected and just treated well throughout the transfer and not experience that hostile situation. That's really our main concern. And then, of course, just making sure it's a safe transfer. The baby's still breathing, the baby stays warm throughout the transfers. Those really are our main concerns. Diane said we can put in a laryngeal mask. That's correct. We have what's called an LMA, laryngeal mask, for a baby. Again, we're not very well trained in it. We don't use it that frequently. We carry them. If we need it, we will use it. But yeah, we do have those available.
So we're still getting some questions around this clarification and transport in the recessive cradle. You know, again, I don't think this is a transport device, you guys. I think that this is just a way of, you know, positioning the baby to optimize their airway and to do CPR. This device then needs to be strapped to a stretcher, similar to a backboard would need to be strapped to a stretcher. So I don't think that there's much, I don't have many questions about that. But we will reach out to MIMS about the medical direction piece.
And then I'm just thinking of a situation in which a recessive cradle was lost once the baby got to the hospital, and they are precious pieces of equipment. So
pretty expensive.
I don't know what a protocol would be to like get that back, or how that would work.
All right, so somebody's still bringing up this issue of the transport device and credentialing. That's fine. I can add that letter. I can add that piece onto the email that we generate towards MIMS. That's fine.
I just wanted to address that a little bit in that, you know, once the baby leaves our care and transfers to EMS, you know, if we are resuscitating, the baby is not breathing, they still need to be resuscitated. So that's the reason why we have in a couple of cases used that device for transport, because the baby still needs to continue, their airway needs to be open, and they need to continue being resuscitated until they get to the hospital. So unless, you know, you have another way of doing that without using that device. And traditionally, you know, when in the NRP class, they recommend like using a shoulder roll, you know, rolling up some blankets, and this device, you know, you don't need all of that stuff. So everything's on that board right there. So, and that's why the straps were added to the most recent model so that it could be used for transport. But yeah, again, I don't know about the legality of that.
Is it true that a baby has to be transported in a car seat? Is that correct?
Yes.
So that is a problem because of the airway situation.
Well, I don't think it has to be a car seat during resuscitation, I guess is what we're bringing up.
If the baby has to be resuscitated
Sean, wouldn't
during.
this be the case? This is where you mark on the EMAs exceptional call and you document this is the once in your career that something like this has happened, and it automatically goes into the medical director's review of the situation.
Yeah, I mean, I agree, but I think
I wouldn't be scared of the device or working with somebody anymore. I think I've learned the hard way over years, but I think that's what those procedures are there for. But once in every 4 or 5 years that this happens, and we do have a review process. And it's medically directed by our physician medical directors. Therefore, I'm not sure if it's all worth the panic here. I think what we're doing now is right, and learning about the people in our community and what services they offer.
Yeah, completely agree. And some good points have been brought up that we just need to clarify in response to questions that are being raised. Yeah, but I think it's a tremendous value to better understand our community, what's happening out there, how can better work together. Yeah, we clearly have the same goal. And it's a perfect marriage, right? Again, these are, I don't know if other providers aren't really speaking up, but for my practice in the pre-hospital setting, these are infrequent and high-risk events that make me very anxious. I'm
I had a question
glad to have someone there. Go ahead.
For everyone here, and Mari, I don't know if you have experience with this. One in particular situation where transport, I think, can get a little tricky is like an cord prolapse situation. So when the umbilical cord, when the waters break, kind of gets in between the cervix and the baby's head and gets compressed. And so as midwives, we're trained in how to hold the baby's head away from that cord until the person is able to birth the baby in often an OR in a cesarean birth. And I haven't, thank God, had the situation yet, but I have heard stories of midwives who fight about that transport situation because you cannot take, you can't remove your hand and put the pressure on the cord, or you risk damage to the baby. So I'm wondering if, Mari, you have experience with that, or any of the people on this call, and how we can, as midwives, better kind of explain the situation if that were to come up, and if you have the equipment, like if we should know a name to ask the EMTs to bring in of a certain stretcher or something that would be helpful.
And actually, we usually put mom in a knee chest position. So she's like on her hands and knees while we're holding the baby's head off the cord until she can have a C-section. Because if the cord's compressed, that means the baby could die.
So this is something that comes up once every 100,000 births or something like that. The most common reason for cord prolapse is artificial rupture of membranes, which is something that most home birth midwives avoid, except in extremely rare circumstances where the baby is very well applied to the cervix and there's little or no chance of the cord prolapse. I've seen 2 cord prolapses in my entire career, and both of them were in situations where a resident ruptured someone's membranes when they were not even in active labor and were only 1 centimeter dilated, and the baby's head was too far up. And so it's just a very, very unlikely situation to happen. But I hope that if that did happen and the midwife explained to the EMT that if she let go of the baby's head, the baby could die, I really hope that they would let her keep doing her job. I've been doing, transfers from time to time in Maryland for decades, and I've never had an EMT tell me, no, you can't do your job. I mean, in general, they've been just absolutely wonderful.
In this situation, like we wouldn't want the mother lying on her back strapped down to a stretcher.
Okay.
So.
People are saying, yep, we would transport the same way.
Thank you.
When do you guys want to do some ride-alongs?
That'd be fun.
I would love to do that sometime.
May I ask a question, please?
Maybe not during a pandemic, but
Yes, please.
Hey, Sean and everybody. I appreciate everybody being here. I think you guys are fantastic, and I value very much your being here and your view of the world. I think it's terrific, and I've had the blessing to attend a couple of some midwife births, some home births, and they've been amazing experiences. How much do you know of the protocols with which we all operate? Are you familiar at all with them? Some discussion has gone back and forth about some generalizations that aren't necessarily true in how we do things and how the childbirth algorithm has changed over the years to accommodate a neat chest, to accommodate left lateral recumbent, to accommodate some of the more desirable transport methods for both mom and baby. Are you familiar with anything that we're doing?
No, we're not.
Please share.
Yeah, I certainly am not going to be able to summarize. Certainly send along a copy of the protocol that MIMS educates on.
Yeah, if you could send us the protocols, we can definitely share that with our group.
Sure. Ian, anything else to add to that, friend?
Oh, no, you guys are fantastic. I'm really enjoying tonight's meeting.
Thank you.
Yes, we've sent around also the sign-in link again, last chance. If you need CEUs for this, please feel free to look in the chat for that link. And actually just posted it again.
I'm really sorry, but I'm going to have to jump off because I have a possible person in labor texting me. But I just wanted to say that if there's anybody that works in Montgomery County that wants to be in touch with Mamas, we would be happy to, have a Zoom chat with you or a cup of coffee or deliver donuts to your station or whatever. We would love to get to know you better. Thank you so much for having this.
Yeah, we would love
Thank
to
you so much.
expand. We'd love to expand this, education session to all over the state, really.
Yeah, so certainly for Baltimore County, this will be posted to their Fire Academy, where providers will be able to access this content in perpetuity and to get CEUs for reviewing this content as well.
Sean, I have a suggestion for you. I know MIM sponsors various EMS seminars, at least prior to COVID-19. But I'm thinking that it would be beneficial that perhaps they would get an invite to present at some of the EMS seminars like EMS Care and so forth. And their MIMS Continuing Ed could probably facilitate that.
John, do you think that you could hook Bayla up with that? Is that possible?
I can certainly try. I have not dealt with them in a while, but I can make a few phone calls and I can try to get some information for them. Yes.
That would be incredible, and I'd be happy to serve as that intermediary. Thanks for bringing.
Excellent. We'll take care of that.
I think attending some of these conferences now are a little easier, right? Because you're doing it from your own home. I love it.
And like Sean said, we're part of AIM, the Association of Independent Midwives of Maryland, which are specifically home birth midwives from all over the state. I posted our website on the chat. If anybody has questions or, somebody already asked if they could come see a birth, we'd be happy to try to make that happen. My practice with Hannah is charmcitymidwives.com. We're located in Pikesville, the Stevenson Village area is where our office is. So we would be happy to, have people come and meet a client and then try to get you invited to a birth if you'd like to.
Ian was kind enough to send out a link. I don't know if you guys can grab that link in the for our midwives, and this is a link to the protocols.
Perfect.
And then it even goes on to say, somebody goes on to say it's page 106 of the Maryland protocols.
Yeah, the algorithm is really kind of it's tough because you have as we all age and we grow in our practice and we grow in our experience, we tend to have more flexibility, like Harold was talking about, like Sean's talking about. you know, you get to know that there's a lot more than a square box to operate in, that we use people as subject matter experts or SMEs. We use them in conjunction with our relationships with our physicians and on you know, remote base stations and things like that. So we get this really good sort of flavor of how to do things. And many times what we see as our younger providers, these are guys who and girls who are brand new and who have been hit over the head with the protocol and say, this book is the only book you shall read, and this is the only thing that you shall listen and follow. And when you do that, then you have that brand new EMT who comes to your home birth and says, oh my gosh, she's bleeding. And you're like, it's okay. We've done this hundreds of times and it's okay. But no, she's bleeding and the baby's not here yet. And we have to go to the closest hospital. But that's not where we need to go. We, you know, and you in your practice, they're saying, we probably want to go to X hospital, but X hospital's further, or X hospital might be on diversion. And right or wrong, to my brothers and sisters in Baltimore, you know, you understand that many cases, those ERs don't even see your patient, right? You go straight upstairs. At least at Holy Cross, you're going to third floor. You're upstairs. At Shady Grove, you're going third floor. And everywhere else, you're just going right upstairs and you're meeting the doc basically in the elevator. They're coming down to you to walk you upstairs in the isolette. So it's tough when you see that book that I sent, you know, that link that we sent, and you look at that algorithm on page 106, it is do this, then do this, then do this, then do this, then do this. It's a flow chart, and nowhere is the mention of a subject matter expert, a midwife, a lay midwife, anything else besides, you know, that EMT who shows up, who just graduated the academy 3 weeks before. And that EMT looks at that and says, okay, I'm in charge. Okay. Do you want me to deliver the frank breech, or do you want to do it? Like you had mentioned before, Bayla.
Right.
Yeah, I think the response, I completely agree with you. Very well said. Perfect tone. I think that, you know, it comes out of a place of fear for sure. Right. I've never done this. I haven't done this a lot. Things aren't looking great. I need to move.
And that's where we have a lot of that sort of where we train our folks to look at things in terms of 5-minute bites, right? We train those folks that ride fire trucks. You're looking at a 5 or 10 minute bite. 5 or 10 minutes, nothing's happened. Let's move. And and as midwives, you look at that and say, but we're not even in the first stage. It's okay. You know, let's progress through this. You know, mom is getting tired, but I think we're okay. We just want you here to stand by. Or maybe I ran out of oxygen and I need some of your resources. Believe me, on my medic unit, they're yours. I mean, anything you need from me so that we can keep mom and dad safe and healthy at home is perfect, right? It's only when something goes wrong, at least for me, it's only when something goes wrong that I rely on your expertise to say, this isn't where we want it to be. Now we're going to go ahead and transport. I'm going to stay here. Let's get our ambulance ready, get it warm, and then we're going to make the right transport decision as I'm, you know, doing the stuff where I, you know, the back of the ambulance is sort of where I know. And if you need something, I'll get it for you and I'll be your hands. And if something goes wrong worse, then I can help you navigate that critical care sort of thing and say, hey, look, you know, this is, maybe we should consider this, or we would normally do this. How do you feel about that? And we work together as a team. I think that that's really what we're trying to say is that ideally getting your name out there and getting out the practice of midwifery is really the goal of these kind of meetings. And I think that you guys are very brave and awesome for doing it. Thank you for being here.
Thank you very much. I really appreciate what you said.
I think in fairness, we should also mention to you as a tool that in most of the EMS systems in the metro areas, there are on-duty supervisory people who are your senior paramedics who are your really your practice experts who are starting to understand practice versus being technician-oriented people. So it's not out of line for you to either, when you call in for EMS and it's really an urgent situation, to identify yourself and ask them to dispatch a supervisor if the priority dispatch doesn't automatically do it, or to ask
won't.
the EMT.
Yeah, I work at
Please
the
call
911 center.
call your supervisor. It would make everybody feel better and hopefully do better patient care. But there is that resource available in most places.
And Harold, you bring up a terrific point. I'm also one of the supervisors at my 911 center, and that doesn't happen. Priority dispatch is what we use in our state, and it's a terrific tool. And you have a lay call taker who is not EMS trained, who is not fire rescue trained, at least in Montgomery. We were the last holdout to have EMTs answering, and we don't do that anymore. And so a person reads a set of cards, just like a flip chart. You know, it's very, very easy. And then as you go through, the most that you can have dispatched to your emergency is the 2 paramedic sort of algorithm, what we call the ALS2 response, where you would have 2 paramedics and a total volume of 5 providers arrive at your scene. It's usually 6, but 5 at a minimum. Now, the EMS dispatch, the supervisor, is not automatically dispatched. And that's sort of one of those things. They either listen up, even if you as providers, as the midwife in charge, and saying, I would like a dispatcher to show up, that's not part of the dispatch and would not be dispatched. I've never.
It's not a dispatcher, it's an EMS supervisor.
Correct. I'm familiar, Harold. I'm trying to get there.
I was listening to what you're saying.
Trying to bring my story back.
Okay.
So as part of the dispatch, you would have whatever's normally dispatched, and that EMS duty officer is what we call them. And for us in Montgomery, that EMS duty officer would either dispatch privately. They would hear something that sounds kind of interesting, so they would want to go, or a supervisor like myself would look at the call, read the call notes, and say, this is a bad call. Right. And I want an EMS duty officer to go. The person that's calling on the phone will never get the EMS duty officer to respond just because they asked for it. It doesn't happen. It truly will not happen. Yeah. Not in Montgomery.
I want to pause for 1 second. Captain Stewart wanted to chime in and has been texting. Lenny?
Yes. So I wanted to thank these ladies. It's outstanding to hear that information. I wanted to add on to what Ian said and Harold said, retired Chief Cohen. So in Baltimore County, on a couple different notes, we do have high-risk pregnancies that should dispatch a medical box. So in this particular case, depending on what these ladies report and or state, you may get the supervisor, as retired Chief Cohen said, Harold said. And comments to a couple of the questions from an operational standpoint, from an EMS administration standpoint, it's really important for the younger members to understand that these ladies are licensed to go out to the homes and deliver these babies. So it would be no different if I went out onto the scene of a call and I had Dr. Berkowitz there, that we had a complicated airway and he was able to or could intubate. I wouldn't tell him no. He would obviously just go with me and we would transport that patient under his level of care. So these ladies can go with you from a MIM standpoint and assist you, as Ian said, and as Harold said, and operate under their licensed care with you in that transport unit. So by all means, if you're in a situation like that, then you are basically you're working with them, and I'm sure, and I can't imagine they're not going with you. So you're covered from a MIM standpoint in that regards. The other thing I'd like to say, as far as the device that they were talking about, I'm also sure that that's probably not licensed to attach to our stretchers. However, that's been some of the growing controversy with pediatrics and newborns and neonate deliveries as a whole. There's not many devices out there that can safely say this will work. the thing to keep in mind with that is, as long as we're doing the best we possibly can for the patient and the mother and the safety of the child in resuscitation, any device is better than no device. So if we can get that securely strapped and comfortably fixed to the stretcher, and it adds some more stability to the resuscitation or to the delivery or the baby itself, that's probably not a good thing either. I've never been in a case review with Dr. Pollack or Dr. Wittberg or any of the other doctors where a provider has been disciplined in any way, shape, or form, or we've never had, from a risk management standpoint, paid out a large sum of money for somebody doing the right thing under the right circumstances. And Chief Cohen's probably been around a lot longer than I am. I'm sure he can attest to that from his retired days. We don't pay out a lot of money for that kind of stuff. So it was a great conversation. I think these ladies are, doing a great job. And if they have a situation where they call you, work with them under their expertise. And as Ian said, two of you together, you'll have a better outcome. And you're going to be covered, I guess, is the most important thing. Thanks, Dr. Bernholtz.
Thank you.
Thank you. Thank you so much, everyone. This came to being after Bayla and I had a transport last winter that was beautiful, and we were so appreciative of the amazing care that our clients received, and this has been amazing. Thank you, everyone, for all of your comments, and I hope that I never get to meet any of you, but stuff happens and we might. So thank you so much for your time tonight.
Thanks, everyone. Again, the last time, the check-in the Zoom chat is the link for your CEUs. Ladies, thank you so much for sharing your time, your talent, your expertise, and being with us today.
Yeah.
Thank you.
Hope to see you soon.
Nice.
Stay safe.
Thanks so much. You too.